Dear students, good evening. Welcome to the session. And first of all, I should tell you that I'm waiting for the good news as early as possible for those students who have given this exam. And but still, I would like you, though you are definitely going to pass and move on to the next stage, but the next stage is PG entrance exam. And these days, whatever questions are being asked in FMG, they are interchanged with the INI-CET and NEET PG. So even if you have already passed your exam or about to pass, still listen to the session carefully. And of course, for the students who are yet to appear for FMGE, and also for the students who are appearing for NEET PG and INI-CET, because as I mentioned, all these questions are being interchanged and any question can appear anytime to anybody. Now, the very first question which we are looking at is, they are asking for adult derivative of the arrow marked structure. So what do you think could be the answer? Because some of you might have seen this question. And let me just look at the chat. So the adult derivative of the arrow marked structure. So where is the arrow mark? It is here. This is called as the notochord or the axial mesoderm. We are looking at a transverse section of the embryo after gastrulation, means there'll be 3 germ layers. Dorsal cavity is amniotic cavity, ventral is the yolk sac cavity. At the floor of the amniotic cavity will have this blue color ectoderm, and the red color in the middle is the mesoderm. And then your yolk sac cavity on the roof, you will have the endoderm. We'll see another diagram for the same purpose, but question is asking about axial mesoderm, what is also called as notochord. So let us look at some more details. This is the notochord, the axial mesoderm. And as I'm telling, the floor of amniotic cavity will have the ectoderm. At the roof of the yolk sac cavity will have the endoderm. Now, what happens is this notochord is going to induce the overlying ectoderm so that it will become neural plate ectoderm. And that neural plate ectoderm will become neural groove, and then it will become neural tube, and then neural tube will form central nervous system, that is brain and spinal cord. You'll find there are some neural crest cells also appearing, and these neural crest cells will be contributing to the peripheral nervous system and some more derivatives. Now you notice this is the notochord, the axial mesoderm. On the side of that, you will have paraxial mesoderm. And this paraxial mesoderm is going to form somite. Somite will give some derivatives like vertebra and ribs, etc. This notochord degenerates later and forms the nucleus pulposus of intervertebral disc. Intervertebral disc will have a nucleus pulposus in the center, but at the periphery, annulus fibrosus. That annulus fibrosus will come from the sclerotome part of the somite, which is paraxial mesoderm. Not only you have paraxial mesoderm, as you can see here, this is the axial mesoderm, the notochord, which is forming nucleus pulposus. This is the paraxial mesoderm, which is forming somite, will form sclerotome, will form annulus fibrosus of intervertebral disc. You will see there is intermediate mesoderm also, which is contributing to major portion of genitourinary system, kidney, testis, ovaries. And then there is a lateral plate mesoderm. Lateral plate mesoderm will divide into 2 parts. There'll be a dorsal somatic lateral plate mesoderm, ventral visceral lateral plate mesoderm. Now, why it is all important? Because in the question you had options like that. It is the ventral visceral lateral plate mesoderm, which is also called splanchnic lateral plate mesoderm, is going to form the septum transversum, which will form central tendon of the diaphragm. That was in the option. These days they give you some scanning electron microscope picture also. So this is the neural tube, which is going to form central nervous system, coming from neural ectoderm, neural plate ectoderm. And if you are searching for the neural crest cells, they will be dorsal and lateral to the neural tube. These will be neural crest cells. That is what we have shown here also. We have shown them here also. And then this will be the paraxial mesoderm, because the axial mesoderm is here. This is the notochord. So this is the notochord or axial mesoderm. That is the para-axial mesoderm. And you can see a little bit of intermediate mesoderm also, which is going to form genitourinary system, major portion like kidney, testis, and ovary. Let us revise this information once again. Notochord is basically a rod-like structure forming the axial mesoderm, later forming nucleus pulposus. Primary derivative is nucleus pulposus, central component. It is for shock absorption because it is between the vertebra. The other remnants of the notochord you have to remember are apical ligament of Dens, can come as a question anytime. The other derivative is tectorial membrane. So total 3 derivatives of nucleus pulposus. The paraxial mesoderm, which is located on the sides, para means side of the notochord, contribute to somite. Somite will give several derivatives. One of the derivative is it is forming sclerotome. Annulus fibrosus, the outer fibrocartilaginous component. See, whenever you do one MCQ, you should be able to do 10 MCQ in that one MCQ. Means revising last 15-year questions, because these last 15-year questions are important. They keep coming repetitively in the exam, or at least the topics keep getting repeated. So fibrocartilage is not the nucleus pulposus, it is the annulus fibrosus, which is for shock absorption again. And the sclerotome part of the paraxial mesoderm is not only forming annulus fibrosus, it forms ribs and vertebra. Again, some of the MCQ which already have appeared. Notochord is inducing the overlying ectoderm to form the neural plate, will form neural tube, and neural tube will form the central nervous system, which is brain and spinal cord. Spinal cord was one of the options we had. Septum transversum, transverse septum, is coming from lateral plate mesoderm. I told specifically from the splanchnic or visceral layer of lateral plate mesoderm. That too in the cranial region, because diaphragm develops in the cervical region, later migrates to thoracoabdominal region. So cranial. You can do one thing, you can pause the video and go through these details once the session is over, and you can write down some details because all of these details are important. Some 5-6 MCQs already asked in this and about to be asked any time soon. So central tendon of diaphragm formed by septum transversum. So obviously, if you are looking at the arrow mark, your answer is it is going to form nucleus pulposus. Choice number C. Spinal cord will come from the central nervous system, will come from neural tube, will come from the neural plate ectoderm, which was here in this region. From here, the spinal cord will come. If you're talking about the vertebra, vertebra come from the sclerotome part of the somite, which is paraxial mesoderm. And that paraxial mesoderm, is here, this area. That is the paraxial mesoderm that will form half vertebra right side, half vertebra left side. If you're talking about septum transversum, it is coming from here. The dorsal is not, it is ventral, visceral, or splanchnic lateral plate mesoderm. That is the one which will be here, developing here. And that is the one which will be forming the septum transversum or central tendon of diaphragm. Here we'll keep our answer as choice number C. Now, lactating mother, the hormone responsible for breast tissue growth. If it is during puberty or before baby is born, means during pregnancy, then we'll say that the breast growth is depending upon estrogen and progesterone, because progesterone will work on the alveoli level and estrogen will work at the duct level. But then it is written lactating mother, means the pregnancy is already over, baby is born. So they go down because placenta has been removed, the level of estrogen and progesterone will go down. Then who is taking care of the breast development? Actually, that time it will be prolactin. Prolactin should be the answer. Now, what about oxytocin? Oxytocin controls the myoepithelial cells of the milk gland, and it is for milk ejection, basically. Let us look at some details. See, if you're talking about the mammary gland, this is the mammary gland. You see this is the nipple. It'll have these 15 to 20 lobes. Again, one of the MCQ. And in those lobes, you have alveoli or acini. They'll form the milk. And these alveoli or acini, they need progesterone, basically, but prolactin also. Now, when you come to the ducts, the duct is basically under the control of estrogen. That doesn't mean that only estrogen, means chiefly estrogen, but later prolactin also. And as you are talking about lactating mother, the postpartum phase means baby is already born. Prolactin is the primary hormone. Maybe it is for the maintenance or alveolar cell proliferation. It is prolactin. And of course, it will work for continued milk production, because we know that it is being secreted by anterior pituitary after delivery and before delivery also. And after delivery, actually, the levels of estrogen and progesterone will fall. That is why prolactin will take the primary role. When you talk about mammogenesis, that is breast tissue growth, maybe at puberty or before pregnancy or during pregnancy also, progesterone is primarily responsible for alveolar or lobular development. If estrogen, it is working on the ducts. If it is lactogenesis, milk production, maybe it is the production, or maybe it is galactopoiesis, means maintenance of lactation. It is prolactin, secreted by anterior pituitary. And if you say galactokinesis, milk ejection, then it is the oxytocin. And this oxytocin is basically for ejection letdown effect by contraction of myoepithelial cells. A question came, they have shown a mother feeding the baby and asking which hormone is responsible for this. Of course, oxytocin, because you are talking about the feeding the baby means milk ejection, baby suckling, and that suckling effect will result in milk ejection. So their answer was oxytocin. Now, lactating mother, hormone responsible for breast tissue growth. Of course, I'll keep my answer as prolactin, because level of estrogen and progesterone goes down after baby is born. Barrett's esophagus transformation, they are asking. So if you are talking about Barrett's esophagus, it is squamocolumnar junction. And at the squamocolumnar junction, sometimes it may happen that there is metaplasia, dysplasia, and cancer also, adenocarcinoma, esophagus, especially in cases of GERD if they are unattended. And that's what we are talking about. You see, Barrett's esophagus is a complication of gastroesophageal reflux disease, and it is replacing the non-keratinized stratified squamous epithelium, which is normally present in the esophagus, which appears as white mucosa, to be replaced by red velvety mucosa. So lower esophagus is now having intestinal type of columnar epithelium, which will have goblet cells. See, normally stomach doesn't have goblet cell, so you cannot say it is gastric metaplasia. It is intestinal metaplasia. And now it will appear red velvety. My point is, normally esophagus is whitish mucosa, gross appearance. Though the lower part of esophagus, you do have some of the red velvety mucosa. That means it is gastric type of epithelium which is there. Just to prevent, if there is some acid coming from stomach, you just want to neutralize it. That is why some gastric mucosa will be there. But the Z line, zigzag line, is only some 2 centimeter. If this 2 centimeter becomes more than that, this zigzag line or squamocolumnar junction, it is not the gastroesophageal junction. This is gastroesophageal junction. The squamocolumnar junction is higher. If it keep on proceeding upwards, then there is a problem, because now you are having patches of velvety mucosa in the white mucosa, and this is Barrett's esophagus. So when the Z line is moving up proximally, you took one biopsy, Barrett's metaplasia, and it was columnar epithelium with goblet cell. That is why you call it as intestinal metaplasia, as given by Harrison medicine. So a case of GERD, acid keep on going here, and it is actually changing the local arrangement of Z line going upward. So it is squamous cells changing into columnar cells, but intestinal. Why did you add intestinal? Because you have goblet cells. You cannot say it is gastric metaplasia. It is actually intestinal metaplasia, because stomach doesn't have goblet cell. And in the biopsy, you found goblet cell. So your answer should be Barrett's esophagus. Answer should be choice B. Now, as you are moving, next, pituitary adenoma mass, which is compressing optic chiasma. So what kind of visual defect you will get? You see, looking from superior view, this will be left eye and right eye. So this is the right eye, this is the left eye, looking from superior view. It is understood that the peripheral or temporal vision, the fibers, they reach the nasal retina, and they cross in the optic chiasma to reach the opposite side brain. They cross in the optic chiasma to reach the opposite side brain. So peripheral vision, or the nasal retina fibers. So field is temporal or peripheral vision, but retina is nasal, and these fibers they cross in the optic chiasm and they'll be compressed by the pituitary because pituitary is here. Say prolactinoma, adenoma of pituitary is compressing here. If you compress here, that means peripheral vision will be lost, which is called as the bitemporal hemianopia. You see, it'll start like this in the visual field and it will become like this, bitemporal hemianopia, pituitary adenoma. Let us revise some other details also. Looking from the superior view, left eye, right eye superior view, you see if it is the nasal fibers, blue color, they run ipsilaterally and go to the same brain. If it is the blue fibers, the nasal field going to temporal retina, they run ipsilaterally and go to the same side of brain. But that doesn't happen with temporal or peripheral vision. If you're talking about the red color, which is temporal or peripheral vision, these vision fibers, they come to the nasal retina, and they have to go to the opposite brain. So the nasal retinal fibers, they cross in the optic chiasma and go to the contralateral brain. The peripheral vision fibers come to the nasal retina and cross in the optic chiasma and go to the opposite brain. That is why we are telling if there is any optic chiasma lesion, pituitary tumor, then bitemporal hemianopia. Let us start with A. A is the optic nerve is gone. So right-sided, right eye, the optic nerve is gone. What will happen? You will see that the right eye will become blind. Uniocular loss of vision. Left is okay, but right is gone. So A. What about B? It is a midline tumor affecting the optic chiasma, especially the nasal fibers, like prolactinoma. And this is B. You see that peripheral vision is gone. Bitemporal hemianopia. What will happen if I have a lesion at C, which is optic tract, but on the right side? Contralateral homonymous hemianopia. You'll see the lesion is on the right side, but left half of each eye is blind. So we say contralateral homonymous hemianopia. But why the left half of each eye is blind? Because you see, what are these fibers coming from? These fibers are coming from the nasal field of the right eye. And what are these fibers coming from? Red color. They are coming from the temporal field of the left eye. So left half of each eye. Left half of each eye visual field becomes blind if we have a lesion here at optic tract, even optic chiasma. See this optic tract and optic radiation. This is optic radiation or geniculocalcine tract. Even same thing will happen. So what about this lesion D then? Lesion D is same as the lesion C. The left half of each eye is blind, which is called contralateral homonymous hemianopia. But then if the lesion is E, means the occipital visual cortex is compromised, you'll find contralateral homonymous hemianopia, but there'll be macular sparing, central vision still working. Why is central vision still working? Because it is understood that posterior cerebral artery might have been blocked on the right side, and there is occipital cortex compromised, but middle cerebral artery still continues supplying macular area. So due to middle cerebral artery, the central vision is spared, macular sparing. You'll see this is the Eiffel Tower, normal visual field, binocular vision, but here the patient cannot see the Eiffel Tower. Why? Because these cases, you see, they are contralateral homonymous hemianopia. Lesion is on the right side, but left half of each eye is blind. So keeping that in mind, pituitary gland, which is in the sella turcica, floor of middle canal fossa, body of sphenoid, is going to compress the optic chiasma. The tumor could be prolactinoma, and it is bitemporal hemianopia, which you are seeing. The peripheral temporal vision fibers are compromised. As they come to the nasal retina, they were crossing in the midline and they were compromised. That is why bitemporal hemianopia. If you're talking about unilateral blindness, that could be optic nerve before decussation. If you're talking about central scotoma, which was one of the option in the question, it is only the macular area or maybe optic neuritis affecting only that particular central area, then scotoma. And homonymous hemianopia, we have seen it can be optic tract or lateral anchored body or optic radiation, even visual cortex. But if it is visual cortex, you may see macular sparing because additional supply from middle cerebral artery. We are assuming that there was a block in the posterior artery, but middle cerebral artery is still working. So macular area, central area is still working. So if it is a pituitary adenoma like prolactinoma, compressing optic chiasma, your answer is bitemporal hemianopia. Patient presenting with ocular complaints, pupillary reflex is absent, light reflex is lost. There's a mistake in writing. Accommodation reflex is present. This is Argyll-Robertson pupil. Accommodation reflex is present. So if you're telling that light reflex is lost, and accommodation reflex is present, it is Argyll-Robertson pupil. Accommodation reflex present, Argyll-Robertson pupil, light reflex lost. The answer is pretectal nucleus. Now, what is the role of pretectal nucleus here? You see, when we are putting light on the eye, any of the eye, that light will be taken towards the optic nerve, optic chiasma, lateral geniculate body, and towards the pretectal nucleus in the midbrain, which is bilaterally connecting to Edinger-Westphal nucleus. And Edinger-Westphal nucleus control sphincter pupillae ciliaris muscle for meiosis and increasing the lens convexity, that is the accommodation reflex. So the ganglion involved is ciliary ganglion, and through the ciliary ganglion, they can control muscles like sphincter pupillae and ciliaris muscle. When you are talking about light reflex, it is not only pupillary constriction, there are other things also happening, convergence also. So all those things will happen because you have intact pretectal nucleus. But pretectal nucleus can be damaged in conditions like neurosyphilis or some diabetic patients. So that is what we are talking about. If pretectal nucleus is not working, accommodation reflex is present, but the light reflex is lost. So keeping that in mind, pupillary light reflex, how does it work? You put the light on the retina, and which is using optic nerve, sending the information to pretectal nucleus in the midbrain. This pretectal nucleus, which is in the midbrain, is activating the bilateral Edinger-Westphal nucleus, which is controlling sphincter pupillae ciliaris muscle. And there'll be a consensual light reflex. Means even if you show light on one eye, both the eyes will show meiosis. Illumination of one eye, bilateral pupillary constriction. It is consensual light reflex. It happens automatically because pretectal nucleus has bilateral communication with the Edinger-Westphal nuclei. Now, what about Argyll-Robertson pupil? Accommodation reflex present, but light reflex lost. Argyll-Robertson pupil, accommodation reflex, ARP. So accommodation reflex present, but light reflex is lost. Pupil will be small, irregular, myotic, and lesion is pretectal area. Can happen neurosyphilis or diabetic patient, as I mentioned. So this is a case of, you should actually write here, accommodation reflex present. There's a correction. And your answer is pretectal nucleus. Now, Jethalal, as I mentioned that questions of NEET PG and INI-CET coming into the FMGE and vice versa. So we should prepare accordingly. But still, I know you usually remember difficult questions which were asked to you, and you might have answered several easy questions which you may not remember because they were not. See, normally we remember difficult questions, not easy questions. So in this discussion, we find a lot of questions which you have marked answer correctly, and most of you would have passed by this time. Maybe the result is already ready. But the point is, you are preparing for your PG entrance exam. So continue the quest. Quest is lifelong, actually. Learning goes lifelong. Now, a patient is presenting with down and out eye. There is ptosis also since birth, congenital ptosis. So which cranial nerve? Immediately we know it is oculomotor, but we want to find out some details. Dr. Devki is telling this was not the question. Which question, Devki? Can you please mention? Was it, or are you talking about this question, or are you talking about this question? Accommodation reflex. Devki? Anyway, whether it was there or not there, our job is to continue learning. So, as I'm telling, down and out eye, ptosis, oculomotor. Devki, two images given, sir. First image, normal pupil. Second image was light reflex. Light on first eye shown. Both were constricted. Yeah, so that is also one way of doing things. Devki, I understand. What mechanism? So maybe the mechanism what they are asking is this only. Consensual light reflex. Maybe they are asking for consensual light reflex. Maybe. But there was some mention of pretectal nucleus, as the students told. Efferent oculomotor. Yes, efferent is oculomotor. Yes, and afferent is the optic nerve. Optic nerve is the sensory, and oculomotor, because Edinger-Westphal is with third nerve. So third nerve will be efferent. That's correct, Devki. Now, as we, because both considered consensual light reflex, it is consensual light reflex. When you, even if you show light on one eye, both of them will be constricted because the pretectal nucleus has bilateral control over Edinger-Westphal nucleus. That is why consensual light reflex. Pretectal count on afferent. Pretectal will be afferent, yes, because as light is being put here and it is receiving the information, you can say it is afferent sensory, but then when you come to Edinger-Westphal, it becomes motor. When you talk about oculomotor nerve, it is motor. Ciliary ganglion and the sphincter pupillae, it is motor. So pretectal count on afferent, maybe you can say that. Now, talking about this down and out eye patient, you see, not only there is ptosis, you compare the upper eyelid width. Compare the upper eyelid width and you see there is a ptosis. Why ptosis? Because levator palpebrae superior supplied by oculomotor is not working. When oculomotor is not working right side, then right LPS is not working, there will be ptosis. Why there is down and out eye? Down and out eye because the formula is LR6SO4 remainder 3. If third nerve is not working on the right side, sixth nerve is working more, fourth nerve is working more. The sixth nerve, what it does is it will take the eye in abduction, LR6. And what the superior oblique does, it will take the eye down and out, down and out. The action of superior oblique is down, out eye, and it also does intorsion. Intorsion is the primary action, but it also takes the eye down and out. So if the third nerve on the right side is not working, the eye will go down and out because of superior oblique supplied by fourth nerve and also lateral rectus supplied by sixth nerve. That is why the eye is down and out. Why there is mydriasis? Why there is fixed dilated pupil? There is no light reflex and there is no accommodation reflex. Why? Because the third nerve is not working, so sphincter pupil is not working, no light reflex. And the ciliaris is not working, which normally increases the lens convexity for accommodation reflex. So no accommodation reflex. That is why fixed pupil. You are showing light or you are checking for near reflex. There is no meiosis. There is no increase in lens convexity because third nerve is not working. That is why there is a fixed and dilated pupil. Let us revise it. Oculomotor nerve, CN3 lesion, what it does. Down and out eye because what prior answer for that third nerve or pretectal, because both were option third nerve also crossing bilateral. What prior answer for that third nerve or pretectal, because both were option third nerve also crossing bilateral. Okay. So you're talking about consensual light reflex and you're asking for the efferent. So you're telling that whether I should answer pretectal nucleus or the third nerve. I'm not sure that what question was that. Was it really Argyll Robertson pupil or was it just for consensual light reflex? If it is for consensual light reflex, and they are asking for efferent, then you can go for oculomotor nerve. Then you can go for oculomotor nerve. But I need to get the correct question, correct framing of the question for that. But you can go for oculomotor nerve in that case. So here, coming to this patient, oculomotor nerve lesion, down and out position. Light reflex, then oculomotor nerve is fine. So it occurs because lateral rectus is supplied by sixth nerve, is becoming unopposed and taking the eye out, abduction. Superior oblique muscle is innervated by fourth nerve and it is also becoming unopposed, so taking the eye down and out, depression and abduction. Ptosis happens because levator palpebral superior is not working, which is for upper eyelid elevation supplied by third nerve. And there's the unopposed orbicularis oculi. Orbicularis oculi supplied by seventh nerve is trying to shut the eyelid and LPS is trying to contract it. If LPS is not working, then oculomotor oculi orbicularis oculi become more powerful. So seventh nerve supplying orbicularis oculi become more powerful, unopposed. That is why there is ptosis, leading to ptosis. Though gravity also pulls it down. Why there's fixed and dilated pupil? I told you, paralyzed sphincter pupillae, meiosis is not happening. And the ciliaris is not working, which normally increases lens convectivity for accommodation reflex, not happening because third nerve is lesion. So unopposed action of dilator pupillae. Dilator pupillae is supplied by T1 sympathetic fibers. It's still working. If sphincter is not working, dilator will become more powerful, fixed and dilated pupil. Dr. Devki, I have to still work upon this question, but anyway, I think 75% job is done, but still I have to work upon that because I need to get the correct question. Then only I can be confident or satisfied that I have justified my role. So it'll take some time, but you are welcome. And oculomotor lesion, what could be the etiology? It could be cases like superiorbital fissure syndrome, which came to you this time. It could be Weber syndrome also because it also compromises third nerve. Now, what about trochlear nerve? Trochlear nerve is cranial number 4, and it is superior oblique, which is not working. There'll be a vertical diplopia, especially when you are looking downward. Dr. Devki, I think we have WhatsApp group. In that you can communicate. Or maybe after the session, we can chat in the YouTube itself. So they will having vertical diplopia if trochlear nerve is gone, and especially while reading or going downstairs, they keep falling while going downstairs because there's diplopia, vertical diplopia, and there's a contralateral head tilt. So for example, this is right-sided trochlear nerve not working. So oculomotor nerve is more powerful. Trochlear nerve superior oblique takes the eye down and out. But if superior oblique is not working, you cannot take the eye down and out, especially in abducted position. You'll find that the eye is in opposite direction because if one muscle is not working, the other group of muscles become more powerful. So eye is in and up in trochlear nerve lesion. And if the eye affected is right side, they'll have contralateral head tilt to take care of diplopia. They'll read with the contralateral head tilt. They'll go downstairs with contralateral head tilt. Means head will be, if the lesion is on the right side, the tilt will be to the left side, and that is how they read. That is how they go downstairs also. What about abducent? Abducent is sixth nerve. If it is not working, lateral rectus is not working, there will be a medial squint. You see the eye is towards the inside. There will be a medial squint. This is right-sided. Let me zoom. So right-sided medial squint, right-sided medial squint. This is right-sided abducent nerve lesion. Lateral rectus is not working, so medial rectus become more powerful. If one muscle is not working, the other muscle become more powerful. Medial rectus supplied by third nerve will be more powerful. It is abducent lesion. What about the facial nerve? Facial nerve, we know it will be not presenting with eye problems as such, except for leg ophthalmos because orbicularis oculi is there. So facial nerve palsy, palsy muscles of facial expression will be there, not the eye movement. Though it is innervating the orbicularis oculi, and lag ophthalmos will be there, but doesn't cause ptosis or eye deviation. So what happens in facial nerve lesion? You see the Bell's palsy, the wrinkling of forehead is gone on the right side, right facial palsy, right Bell's palsy. Patient is unable to close the eyelid because orbicula oculi is not working. The zygomatic is not working, so the angle of mouth is drooping. So frontalis is not working, the eyebrow problem. Orbicula oculi is not working, cannot shut the eyelid. Buccinator is not working, food gets stuck in the oral vestibule. And zygomatic is not working, drooping of the angle of mouth. This is right-sided element type of facial palsy. Right element type of facial palsy. Not going into much detail, but if the patient is presenting with down and out eye with ptosis since birth, maybe since birth there was a problem with the third nerve, and that is what our answer is. Now, patient is presenting with ptosis, again, ophthalmoplegia. I just mentioned that superior orbital fissure can present like that. So superior orbital fissure syndrome, which can be Tolosa-Hunt syndrome. There's used to be a question. See, all these questions are repeat questions. Tolosa-Hunt syndrome used to be a question. You will find this in Harrison medicine. And it used to come. Tolosa-Hunt syndrome is granulation tissue in the superior orbital fissure encroaching upon the cavernous sinus and can present the same way. Yeah. So as you proceed further, superior view. This is the right eye, right superior orbital fissure. Right superior orbital fissure is present between the lesser wing of sphenoid and greater wing of sphenoid. The lesser wing of sphenoid at the floor of anterior fossa and greater wing of sphenoid at the floor of middle cranial fossa. Between the two fossa, you have superior orbital fissure. Yes, Dr. Devki, 3, 4, 6 and 5, 1. Not 5, 1, answer 5, 1, but the three branches. You have to be careful that superior orbital fissure, 5, 1 is not passing, 5, 1, 3 branches are passing, lacrimal, frontal and nasociliary nerve. You have to be careful about, but you are correct. Your answer is correct. I know, Dr. Devki, you will be getting near 250 marks. Take it from me. I'm very hopeful. We have interacted earlier also, I remember. Now, looking from superior view, focusing upon this area, magnified. So what we are telling here is the number 2, 3, 4, 5, and 6, following them as they come from the brain or going into brain, how they are passing in the cranial cavity. You will see the number 2 is passing in the lesser wing of sphenoid, optic canal. And the number 3, 4, and 6, they are coming from the brainstem, but becoming a content of cavernous sinus before they become content of superior orbital fissure and enter the orbit. Then you see trigeminal nerve, trigeminal because it has 3 branches and they are 5, 1, 2, 3. So 5, 1, 2, 3, you will find only 5, 1 and 5, 2 are cavernous sinus content. Don't worry, Dr. Devki. Have faith. And mandibular nerve doesn't become a content of cavernous sinus. It just passes foramen rotundum. Sorry, foramen ovale. Foramen rotundum, you have maxillary nerve. So maxillary nerve passes foramen rotundum. After becoming a content of cavernous sinus, it will pass foramen rotundum and supply the maxilla bone. Hence the name is maxillary nerve. It is ophthalmic nerve which will be giving 3 branches passing superior orbital fissure. So ophthalmic nerve is not a content of superior orbital fissure. It is a content of cavernous sinus. Because in superior orbital fissure, it will give 3 branches, which are lacrimal, frontal, nasociliary nerve. Lacrimal, frontal, and nasociliary nerve. We'll see. So what are the content of cavernous sinus? What are the content of cavernous sinus? Content of cavernous sinus, you can see here. A question came, which nerve is more medial? More medial is abducens nerve. Which nerves are lateral? Wall of cavernous sinus. It is the number 3, 4, 5, 1, and 5, 2. So okay, let me zoom this area. We are talking about this area, and magnified here in a cut section. Maybe you have taken a coronal section from the front view you are looking. So inside cavernous sinus, you'll see the number 3, 4, 5, 1, 5, 2, 3, 4, 5, 1, 5, 2. They are in the lateral wall of cavernous sinus. One nerve is running through the cavernous sinus, and that is abducens nerve, inferolateral to internal carotid artery. This is internal carotid artery, inferolateral to that, it abducens nerve. So this is the first nerve to get compromised, leading to medial squint because LR6 will be compromised. All of these are MCQs. Now, all of these nerves will be there in the superior orbital fissure also, except for the maxillary, because maxillary nerve doesn't go inside superior orbital fissure. It is going through foramen rotundum. And ophthalmic nerve is a content of cavernous sinus, not a content of superior orbital fissure. Its 3 branches are. So what branches? You zoom this area now, zoom this area, zoom this area, zoom this area, and you'll find that there is a common tendinous ring of Zen. This common tendinous ring of Zen is the one which gives common origin for 4 recti muscle, and it will include the optic nerve in the optic canal also, dividing superior fissure into 3 parts. I'll repeat. This is the common tendinous ring of Zen giving origin to 4 recti muscle. Let us zoom. Recti muscles could be, superior rectus or maybe the medial rectus or inferior rectus. But the point is, superior orbital fissure is divided into 3 parts by this common tendinous ring of Zen. And the LFT nerves are left outside the ring of Zen with superior ophthalmic vein. Now, what is this LFT? Lacrimal nerve, frontal nerve, and trochlear nerve, they are left outside the ring of Zen. Then what is inside the ring of Zen? Inside the ring of Zen, you will have the nerve number 3, upper and lower division. Nerve number 3, upper lower division. And nerve number 6 and nasociliary nerve. So nerve number 6, nasociliary, and nerve number 3. They are inside the ring of Zen, inside the supraorbital fissure. Then what is in the middle part? Middle part, you have inferior ophthalmic vein. All of these are important relations. But anyway, this is supraorbital fissure. You have 3 sensory and 3 motor nerve. What are the 3 sensory, 3 motor nerve? The 3 motor nerve are 3, 4, 6, the formula for eyeball, nerve number 3, 4, 6. And what are the 3 sensory nerves? The 3 sensory nerves are branches of ophthalmic tribanal, lacrimal, frontal, and nasociliary. Total 6 nerve pass in supraorbital fissure. Lacrimal, frontal, nasociliary of ophthalmic tribanal, and nerve number 3, 4, 6, which control eyeball muscles. With that idea, you should know if the ophthalmic nerve, let us zoom this area. If ophthalmic nerve is involved, then sensory problem will be in the forehead, upper eyelid, and tip of the nose. The upper eyelid, forehead, and tip of the nose, not the lateral side. Because lateral nose or lower eyelid or upper lip, this is maxillary nerve. Maxillary nerve is upper lip, lateral nose, and lower eyelid. Maxilla area, cheek area. And mandibular nerve, which is a mixed nerve, sensory motor, because it supplies muscle of mastication also, but sensory also. It'll take care of lower lip or the area over mandible. So lower lip and area over mandible, but except the angle of mandible, because angle of mandible is supplied by greater auricular nerve, root value C23, chiefly C2. Greater auricular nerve, which supply greater part of auricle also. So keeping all that in mind, superior orbital fissure syndrome, example Tolosa-Hunt syndrome. After this session is over, you can rewatch the session and take a screenshot if you wish. Ophthalmoplegia and ptosis. The key cranial nerves which are involved, oculomotor, trochlear, and abducens, nerve number 3, 4, 6, supplying the eyeball muscles. Additionally, branches of the ophthalmic triangle, LFN, lacrimal frontal nasociliary, lacrimal frontal nasociliary. L for L, lacrimal is lateral, then frontal, then nasociliary. Nasociliary is the nerve which carry the corneal reflex, also touch the cornea. Nasociliary nerve is activated, that is the afferent for the corneal reflex. Sensory disturbances will be there in the forehead, upper eyelid, and tip of nose, as I shown in the diagram. In supraorbital fissure syndrome, LFN branches are compromised, ophthalmic triangle. Syndrome also is impacting superior inferior ophthalmic vein, as we have seen. There can be papilledema also if they are compressed. Tolson syndrome is associated with granulation tissue, which is in the supraorbital fissure, but extending into cavernous sinus. All of this discussion is important for your next coming FMGE, NEET PG, and INI-CET exam. So, patient presenting with ptosis, ophthalmoplegia, supraorbital fissure syndrome, 3 motor and 3 sensory nerves, and this is your answer. You cannot include optic nerve here because optic nerve is not in the supraorbital fissure. It is passing the optic canal. And you cannot include phi 2 here, maxillary nerve, because maxillary nerve is a content of cavernous sinus, but passing foramen rotundum. It is not passing supraorbital fissure. So only possible answer is choice number A. Now, another question come, which is, this is the floor of the orbit, but here you see inferior rectus is moving into maxillary antrum because there is a fracture at the floor. So teardrop sign, that is what you are seeing here, teardrop sign. Okay, so there was not mention of supraorbital fissure. maybe. So that's what, you have to correctly give me the question. Sometime even a small change in the stem of the question can change the answer. But anyway, the purpose of this session is that try to cover up as much information as possible. What is gone, but there is something which is coming also. Blood fracture, yeah, blood fracture, yes. So teardrop sign, X-ray, classical reading, blood fracture, like cricket ball injury or somebody punched. So floor of the orbit is fractured. Orbital contents like inferior rectus by hernia, that is why leading diplopia into maxillary antrum. Now, thinnest wall is, of course, middle wall because ethmoid bone, lamina papracia, which you can see here. This is the orbit. So middle wall, lamina papracia, because ethmoid air sinuses are there. But somehow, documentation of middle wall rupture in blowout fracture is less as compared with the floor. Reasons being given mechanistically. There is a hydraulic theory and there's a buckling theory that the floor is more involved than the middle wall. So we can follow that any anterior trauma, maybe fast moving balls or fist, they compromise, the anterior trauma compromise more of the floor rather than middle wall. So just pause the video and take a screenshot. I have done all the research and given you some information. Of course, it is not an anatomy question directly as per se, but you never know. They can start asking deep into the topic. 32-year-old, headache, nuchal rigidity, NC-CT, non-contrast CT diagnosis. You see this, There is central whiteness and extending like stars. Star of death, that star. So let us compare. Of course, like if it is star of death, then this is going to be circle of Willis area, rupture of berry aneurysm, cerebral hemorrhage. This is the case of cerebral hemorrhage, but let us compare it with other hemorrhages also. If it is extradural hemorrhage, epidural, which is other name, it could be a fractured pterion, an anterior division of middle meningeal artery compromised, lucid interval, loss of consciousness, period of consciousness, followed by another loss of consciousness. There can be transfrontal herniation, up again down and out eye because third nerve compromised. The CT scan and CCT will show lentiform or biconvex shadows, hyperdense because acute bleed, arterial bleed, dangerous bleed, patient can die if you don't respond immediately. But the bleeding doesn't cross the suture line. Let me zoom. So fracture at pterion, meeting point of four bones, frontal, parietal, squamous temporal, greater vingus sphenoid. And it is the anterior division of the middle meningeal artery, which is under the pterion, might bleed to give extradural hemorrhage. Hematoma is biconvex, may compress transtentorial herniation, third nerve may be involved, down and out eye. And it is whitish, hyperdense because acute bleed. If you're talking about subdural hematoma, then bridging veins, superior cerebral veins can be damaged. Presentation usually elderly patient or maybe chronic alcoholic, brain shrinking, or shaken babies. Concavo-convex shadow, hyperdense if it is acute, and hypodense if it is chronic. So, and this bleed can cross the suture line because it is under the durameter. So as you're talking about subdural hemorrhage, it could be acute bleed, hyperdense shadow, crossing the suture line, convexo-concave shadow, subdural hematoma, bridging veins. All of these are MCQs. Now it could be acute bleed or it could be chronic bleed. And they're usually not emergency because veins bleed, they stop, bleed, stop, bleed. If it is a large hematoma, then it is an emergency. It is not an emergency as extradural hemorrhage. The previous one was emergency. It's always an emergency, but this may or may not be emergency. So this is the subdural hematoma. What about the subarachnoid? Cerebral hemorrhage, common cause, rupture of cerebral berry aneurysm, saccular aneurysm, circle of Willis. Anterior is more common, anterior communicating than posterior communicating. Severe thunderclap, headache, worst headache of my life, nuchal rigidity, xanthochromia, lumbar puncture because CSF is All these blood vessels are in the subarachnoid space. If rupture, then blood will be in the CSF, lumbar puncture, xanthochromia, because of blood in the CSF. CT scan, hyperdense area, basilar area, that star shape, death star of death, as you are telling, and it may encroach into sylvian sulcus, also lateral sulcus, sylvian sulcus of the cerebrum. So as you see, it will appear like this, and it is going inside the ventricles also, because there's communication. And as we are telling, anterior communicating artery aneurysms are more common than posterior communicating artery aneurysm. This is 40%, that is 20%. When the anterior cerebral artery give anterior communicating artery, right where it is given, you can have this, or where the central carotid artery is giving posterior communicating artery, at that point there can be. So if it is posterior communicating artery rupture of aneurysm, or maybe anterior communicating artery rupture of aneurysm, it can bleed, giving subarachnoid hemorrhage. What about intracerebral hemorrhage? Pseudo-subarachnoid hemorrhage. Pseudo-subarachnoid hemorrhage. Just a second. Acute headache, vomiting, and it was given, but no, there was some hypotense area too. Hypotense area, then it could be subdural hemorrhage, Dr. Devki. So you're asking about pseudo-subarachnoid hemorrhage. Pseudo. It is mimicking the subarachnoid hemorrhage, but not due to actual bleeding. And on CT, it may mimic. It could be diffuse cerebral edema or encephalopathy, meningitis, etc., etc. If you take a CSF tap, it will be clear CSF, whereas in subarachnoid hemorrhage, there is xanthochromia. And the subarachnoid hemorrhage is basal, and this will be more generalized pseudo SH. The true SH will present with severe headache of my life, but pseudo SH will present with hypoxia, infection, etc. So you can get confused with pseudo, but there are some differentiating features. So intracerebral hemorrhage, if you are asking about, then it is hypertensive patients, Charcot-Bouchard, rupture of aneurysm, hypertensive patients, systemic hypertension, rupture in the putamen area, basal ganglia disorders can be seen. Putamen or lenticular striate branches of middle cerebral artery may rupture, and intracerebral hemorrhage. Pyogenic and diffuse, one in between. It was not clearly. Okay, so it was not subarachnoid hemorrhage. If it is pyogenic, then it could be pseudo. So was there any option like pseudo SH? Was there any option like pseudo SH? Dr. Devki? So here I'll take my answer as subarachnoid hemorrhage, but I understand that question was different, as Dr. Devki is mentioning. But in this particular setup type of question, I'll have to take answer as subarachnoid hemorrhage. Now, patient after parotid excision, you are patient is experiencing sweating and redness in front of the ear. Front of the ear, parotid removed. We immediately think of Frey syndrome. Frey syndrome means what happens is, okay, so no options for pyogenic and diffuse and SH. No, was there an option of pseudo SH? So Frey syndrome, what happens is, like this is parotid gland. It is controlled by glossopharyngeal nerve, the secretomotor parasympathetic fiber. But if you remove the parotid, some of the fibers will be compromised, and they can actually innervate some of the sweat glands, which are in the area, especially greater auricular nerve. So the territory of greater auricular nerve may be involved, and there may be sweating while the patient is smelling or thinking about food and having food. Okay, so again, this is one question, Dr. Devki, I'll have to work upon, because there was no pseudo SH given. I'll have to work upon this. Let me just discuss it with the medicine people also, because they'll be taking care of this question, that subarachnoid hemorrhage, pyogenic or SCH or pseudo SH. So that is what happens, and it is a case of Frey syndrome, of course. As you see, this is the territory of greater auricular nerve. Greater auricular nerve. Greater auricular nerve has anterior branch, posterior branch. It has C2-3, but chiefly C2, you should remember when there's an option, C2 is better answer, but C2-3 dermatome. Supplying greater part of auricle and also skin at the angle of mandible. Otherwise, mandibular area is under mandibular nerve. So mandibular nerve supply the mandibular area, but except the angle of mandible, because angle of mandible and most of the auricle, especially posteriorly, is all under the great auricular nerve. So what happened is, like, as you remove the parotid gland, the great glossopharyngeal nerve was compromised. It was regenerating and it has innervated the sweat gland territory of the great auricular nerve. That is what has happened. So patient will have in front of the ear means whenever the patient is having food, the central nervous system will activate the glossopharyngeal nerve for the parotid secretion, but there is no parotid gland, so they'll secrete sweat only. That is what happening. And remember the sternomastoid, behind the sternomastoid, almost midpoint, you have 4 nerves coming out. They're coming from cervical plexus. One of that is the great auricular nerve, anterior division, posterior division. And this great auricular nerve, another question came, thickening of great auricular nerve, leprosy. So this question came, you were given one option and there was this thickening of great auricular nerve. So leprosy patient, the same great auricular nerve which supply greater part of auricle, it supply mastoid area also, behind the ear, in front of ear, most of the auricle, not only laterally but medially also. The tragus area is auriculotemporal nerve, branch of mandibular trigeminal. But then, so what are the other branches from the cervical plexus? Lesser occipital nerve, which supply this part of the auricle medially, upper auricle medially, not laterally. That is lesser occipital nerve. And supraclavicular nerve going above the clavicle, C4 root value. Type 1 leprosy, yes, type 1 leprosy. Type 1 leprosy, it was by that pressure level mark wrong. Why? Erythroplaque. Erythroplaque. Okay, you are talking about the this great auricular nerve question, Devki. Erythroplaque. What is erythroplaque? Raised erythroplaque. It is not a recognized lesion. It is a pre-malignant red patch if it is erythroplakia. Carcinoma, tobacco user. Well defined erythematous hypoaesthetic plaque can be there in tuberculoid leprosy. Lepromatous, they are telling. Lepromatous of borderline, the great auricular nerve can be thickened. Posterior border sternomastoid. Tuberculoid, thickened, characteristic. Both they are telling. Anyway, again, that means again I have to work upon this type 1. Yeah, so it is kind of a derma plus anatomy question, you can say. There are some questions which still have to work. This is right-sided Horner syndrome. Why would you say right-sided Horner syndrome? Because it is an option of the question. That is why I'm taking it here. You see upper eyelid and upper eyelid. There is a ptosis, partial ptosis, because superior tarsal muscle, part of Miller, is not working because T1 sympathetic fibers are not working in Horner syndrome. So Horner syndrome, T1 sympathetic fibers are not working. Superior tarsal muscle, part of Miller, is not working. That is why there will be a partial ptosis, first of all. Along with partial ptosis, you know, because T1 sympathetic fiber is not working, so dilator pupil is not working. As dilator pupil is not working, sphincter pupil will be working, there will be meiosis. So meiosis and ptosis. These patients will have meiosis and ptosis, and they'll have another thing, which is anhidrosis, loss of sweating. So anhidrosis, loss of sweating. Congenital, hence there is heterochromia. Yes, very good, Dr. Devki. Because it is congenital, you can see heterochromia iridis also. See, this is brown color pupil, dark brown appearing like black, but this is blue-green iris. So heterochromia iris, a feature of congenital Horner syndrome. This would have happened less than 2 years of age. So if the lesion happens before the age of 2 years, there will be heterochromia iris also in Horner syndrome. So patient after parotid surgery experiencing excessive sweating, redness in front of the ear, that means territory of greater auricular nerve, and it is a case of Frey syndrome. Loss of ventral nerve involvement, as such, you cannot say. It was auriculotemporal nerve involvement. It was damaged. That is why it is also called auriculotemporal nerve syndrome. Horner syndrome, no. So we'll keep our answer as Frey syndrome. Patient presenting with fish bone stuck in the pyriform sinus. Repeat question. Endoscopy removal, iatrogenic injury, accidental, iatrogenic injury by doctor. And of course, internal branch of superior nerve. Frey syndrome, they just gave it reverse. In Frey syndrome, they gave it reverse. Means, Dr. Devki, can you explain? So here what happens is you have to remember the posterior most tongue, the epiglottis, posterior most tongue, epiglottis, and till the vocal cord. You have one nerve of vagus, superior nerve, branch internal laryngeal nerve. That is working for cuff reflex also. I'll repeat. Vagus gives superior nerve, give internal laryngeal nerve. Internal laryngeal nerve supply posterior most tongue, epiglottis, and also sensation till the vocal cord. So this is all under internal laryngeal nerve, branch of superior laryngeal nerve. Nerve of fourth arch. It is the fourth arch which form the posterior most tongue. It is the fourth arch which form epiglottis. So all this is fourth arch nerve. Frey syndrome question and options for symptoms of it. Okay, so in Frey syndrome, they gave symptoms instead of giving these names of the these syndromes. That is what you are telling. Yeah, so I'll have to work upon that again. So this is basically fishbone removal and the internal laryngeal, as I'm telling. Let me give you some more details. This is you taken a coronal section, but looking from posterior view. So that nasal cavity, nasal septum, the turbinates can be seen from posterior view. Nasopharynx basically. Then oropharynx, and then laryngopharynx behind the larynx. You are looking from posterior view. 3 pharynxes. You'll see this is the uvula of the soft palate, and this is epiglottis. This area is the oropharynx, where you can see posterior most tongue also with tonsil, palatine tonsil tongue and all that. But if you're talking about laryngopharynx, you are behind the larynx, and it is starting from the epiglottis level. They're going to be more known about definition and want to know more mean that focus on diagnosis. Focus on diagnosis. So epiglottis, now you can look inside the larynx also, but right now you are in the pharynx. And in the pharynx, on the sides of the larynx, you have piriform fossa. So piriform fossa is basically laryngopharynx. It is laryngopharynx on the either side of the larynx. If you are going inside, then it is larynx. Sometimes fishbone may be stuck here. Sometimes, it is also called smuggler's fossa because some people used to smuggle diamonds keeping there. So fishbone can be stuck. A nerve runs here, the same nerve, internal laryngeal nerve, branch of superior laryngeal nerve, branch of the vagus, that can be damaged. So you see, now we are doing laryngoscopy. You find that this area is the arytenoid. On the cricoid, you will have arytenoid. On the arytenoid, you will have the corniculate. So cricoid, arytenoid, and this is the area, corniculate and cuneiform, posterior wall. That is the larynx, and below that will be trachea. And these are the vocal cords. So this area basically. You can also say it is in front of that is epiglottis, and behind is this piriform recess. And this is something stuck here. So that is trachea. This is the vocal cords, infraglottic and supraglottic. So this is supraglottic area. But it is not larynx, it is laryngopharynx. And a nerve which passes here is the interlaryngeal nerve. So that could be fishbone. And while you are removing the fishbone from piriform recess from this area, you have damaged the interlaryngeal nerve. It's dangerous now because it is for cuff reflex. The patient might develop aspirations in the lung now because fluid may pass into lungs because cuff reflex is gone. Maybe from one side, but it is not. So you should be careful while doing such endoscopic removals. But anyway, answer is interlaryngeal nerve. This kind of examination was taken by them. Yeah. So the level of exam is gradually changing. Yeah, trying, Dr. Devki, trying. So inspiratory stridor, another question. But after prolonged ventilation, they were asking why. It is because of subglottic narrowing. This one, another question. It is different question. And post intubation, this happens that there is a subglottic stenosis. Subglottic region is the narrowest part of the glottis, the larynx in children, but also in the adults. Though the narrowest is glottis, in adult glottis is narrowest, but subglottis is also quite narrow. Point is, if the question is asking prolonged ventilation and there is inspiratory stridor, which area was responsible? You should say subglottis. ENT professors will tell you better. Anesthesia people will tell you better. So this is anatomy plus anesthesia plus ENT. But take a screenshot, and this is confirmed statements. Another question. Maxillofacial trauma, inability to ventilate. This can happen sometime. So cricothyrotomy is the next best step you can do. Facial injuries. Because your laryngeal mask airway is also not working. Actually, it is not recommended because there is facial injury like maxillofacial trauma. So LMA is contraindicated because there is distorted facial, and anyway, it is supraglottic airway. You have to go infraglottic here. So tracheostomy, too time consuming for emergency, and it requires a specialist also. Whereas, yes, ENT people, I need their comments because I am having knowledge of ENT. I read ENT books, but ENT specialists will always be better than me, of course. I'm specialist in anatomy. Anatomy, I will be better. Now, cricothyrotomy, how do you do? It can be done by house surgeon also. In fact, you don't need anesthesia people for that. What you do is feel for the thyroid, that big cartilage here. Just below that, you have cricoid, the ring-shaped cartilage. Between the two, you have cricothyroid membrane. That is where a simple needle you can put, and some sound will come, and patient start breathing below the larynx, infraglottic, basically. So this is the area, cricothyroid membrane, which will be inside. Ligament is outside, membrane will be inside. That is where. So above you have thyroid cartilage, and below you have cricoid cartilage. Between them, cricothyrotomy. Now, what about this question? 30-year-old man, choking episode after ingestion of fishbone. They are very fond of fishbone these days. And fishbone got impacted level of T4. Now, maybe these questions are appearing casual, but they're not casual. You have to be very careful about such questions. But anyway, you know T4. So I'll take the answer as Archafyota. Why I'm telling don't take it casual? Because ENT people say there are 3 narrowings. The anatomy people say there are 4 narrowings. And radiology people say, like Sutton, 5 narrowing in the esophagus. And they are physiological. So that is why you have to be careful. Let me give you some details. This is Sutton radiology. It will tell you that there are 5 narrowings. And ENT people say that there are 3 narrowings. So what should you follow? Better follow Gray's anatomy, if possible. See, just at the beginning of the esophagus, 15 centimeter from upper incision, C6 level, there is a cricopharyngeal sphincter, the narrowest lumen of esophagus. That is the first narrowing. So beginning of the esophagus, cricopharyngeal sphincter, C6 vertebra 15 centimeter from upper incision. The second is due to aortic arch. T4 level. Aortic arch T4 level 23 centimeter. I have read Sebastian surgery, so you keep it 23 to 25 centimeter. I'm adding here something in Gray's anatomy. It is 23 to 25 centimeter. So when you get 23, 25, you should answer it as T4 or arch of aorta. Now, the third is left principal bronchus compressing the esophagus posteriorly. Left principal bronchus compressing the esophagus posteriorly. And left principal bronchus T5 to T6. Remember, it is T5 to T6 and it is 25 to 28 centimeter. I'm modifying Gray's anatomy here. Why? Because surgery books are writing like that. So left principal bronchus, it is T5 to T6, I'm adding, and it is 25 to 28 centimeter I'm adding. Though I'll prefer 28 T6 and left principal bronchus because then it is clean Gray's anatomy. But as I told, Sebastian surgery, aortic arch T4, 23 to 25 centimeter, add it. And 25 to 28 centimeter, T5 to T6, add it. Left principal bronchus. I'm adding some details in Gray's anatomy. And of course, esophageal hiatus, T10, 40 centimeter. Esophageal hiatus, T10, 40 centimeter. But what about this here, left atrium? Left atrium, 30 centimeter from upper incision. 30 centimeter from upper incision, this is an additional thing. And this, radiology people will consider normal, but we don't consider it could be left atrial hypertrophy. If there's a left atrial hypertrophy, maybe that is why. So the point is that it is always better when there's a confusion, better to follow Gray's anatomy. You can modify a little bit according to surgery people. But radiology people are doing excess. They are telling that left atrium is producing a normal physiological narrowing. That is not happening. It must be a case of left atrial hypertrophy. Now, to give you reference, classic diagram 5 physiological narrowing, Sutton's radiology, and Clark and Granger also. So radiology people 5, ENT people 3, anatomy people 4. That is why I told you don't take these questions casually. Anyway, since they already mentioned T4, I'll take my answer as arch of aorta. If it is 23 to 25 centimeter from upper incision, I'll take my answer as arch of aorta. If it was 25 to 28 centimeter, if it was T5 to T6 level, maybe then I'll take my answer as left principal bronchus. Try to understand what I'm trying to tell you, because I have been watching this system for last 25 years. I have seen some 15 to 20 MCQs on esophageal narrowing and having different answers. That is why. Though it is a, maybe you're lucky you got simple question here. Professional singer, difficulty raising the pitch. Raising the pitch means you are talking about cricothyroid muscle. Cricothyroid muscle is the only muscle of larynx supplied by branch of vagus, supralaryngeal nerve giving external laryngeal nerve. External laryngeal nerve. It can happen after thyroid surgery. In thyroid surgery, you have to be careful when you ligate the superior thyroid artery, because superior thyroid artery run with external laryngeal nerve supplying cricothyroid muscle. You have to ligate superior thyroid artery, inferior thyroid artery as close as possible to the thyroid gland. Ligate superior thyroid artery, inferior thyroid artery as close as to the thyroid gland, having different regions. If you ligate the superior thyroid artery away from the thyroid gland, you might damage external laryngeal nerve. You might damage cricothyroid muscle, which is the tensor of the vocal cord. And then the singer will sue you with millions of dollars if you are in US. So not going into this detail because running out of time now. External laryngeal nerve. A question came, they are telling great cardiac vein, another vessel is running along with that, is compromised when doing CAVG operation. So coronary artery bypass graft, you are operating on maybe this artery, that is left anterior descending, other name is anterior interventricular artery, which is shown here, this one. So that was the answer, I believe. Question was, there is CAVG being done And we are working in the territory of great cardiac vein and one vessel damage. Maybe they were asking about left anterior descending artery, which is also called anterior interventricular artery. So anterior interventricular artery, or maybe the left anterior descending artery, that's what they were asking. I haven't got the question properly. Yes, just before the exam, you have to read some of the important notes which you make, Dr. Devki. Or maybe there was a question asking, we are doing segmental resection of BPS, and when we are doing segmental resection of bronchopulmonary segments, one vessel damage. Which vessel? The surgical plane is made by these veins, which are not intra-segmental, they're intersegmental, and they are basically pulmonary vein branches. So maybe that was the question. Question was, when we are doing segmental resection in bronchopulmonary segment, which vessel can be damaged? The vessel which is not intra-bronchus, intra-BPS. So there are some vessels which are intra-BPS, but there are some vessels which are in the periphery, and they are pulmonary vein branches. So they may be damaged because they are creating surgical planes. You as a surgeon follow them, and you should not damage them. They are the one which will carry the oxygenated blood to the left atrium of the heart. So they can be damaged. That kind of question was there. So it is good, Dr. Devki, if you read just before the day of exam and you could answer perfectly right. So that's what I'm telling. A lot of questions you would have answered perfectly all right. You don't remember it because you could answer it perfectly. You remember only tough question which you could not. So be confident that you will get good marks. You'll pass fantastically. House palsy, C56. Running out of time, so I have to go quick. Fall on shoulder, undue separation of head and shoulder, deformity. So House palsy, shoulder cannot do abduction, so in adduction deformity, in medial rotation deformity. Elbow in flexion cannot do flexion, so it is in extension deformity. And there is pronation deformity. So extension deformity, pronation deformity, all that. Undue separation of head and neck can happen, head and shoulder can happen if fallen shoulder like this. That is the case we are telling, or maybe during difficult labor, you are trying to pull the baby out, head and shoulder, there's undue separation. Damage is C56 upper trunk, of Duchenne palsy, nerves like suprascapular axial nerve, musculocutaneous radial nerve. Remember the root value. It is partial lesion of radial nerve, partial lesion of musculocutaneous nerve, total lesion of axillary nerve, total lesion of suprascapular nerve. So adduction and medial rotation because deltoid teres minor not working. There is extension at the elbow joint because biceps is not working. There is pronation because biceps is not working. Placement tip hand deformity. So C56. Now patient presenting with fracture X-ray, which nerve? You know, very frequent questions. Mid-shaft fracture, fracture mid-shaft humerus, radial nerve in radial groove, radial nerve in radial groove. You should remember that if it is surgical neck humerus, axillary nerve damage, supplying deltoid teres minor, deltoid for abduction of shoulder joint, teres minor for lateral rotation of shoulder joint, compromise, fracture neck of humerus. If it is radial nerve in the radial groove, wrist drop, sensory loss, dots of the hand, 3.5 fingers, minus nail bed because nail bed by median nerve. Ulnar nerve passing behind medial epicondyle, fracture medial epicondyle, tardy ulnar nerve palsy, all that can damage ulnar nerve. If there is a supracondylar fracture, then anterior interosseous nerve branch of median nerve damage. OK sign is a problem because deep muscle of anterior forearm not working, supracondylar fracture. So, but here, because it is supracondylar, this is a fracture mid-shaft humerus, you keep your answer as radial nerve with wrist drop. Neuromuscular monitoring, electrode at the following location. Neuromuscular blockade in anesthesia, especially general anesthesia, muscle relaxant. Post anesthesia, you want to check how the muscles are working because you have to tell the patient to walk also. So is he able to or not? See, this is medial side. Here you have ulnar nerve. You are putting the electrode on ulnar nerve. And you are checking for a muscle called adductor pollicis. Adductor pollicis. So monitoring, trade of four nerves you can monitor, but this is for ulnar nerve. Not going into much detail. It is ulnar nerve because this is the territory of ulnar nerve, putting the electrodes there. Diabetic worker, stab injuries, central region of palm, developing swelling, pain, mid and the ring, these two fingers, mid palmar space, mid pus accumulation in the mid palmar space, mid palmar space, B. Giving some more details. There is a thenar space related with thumb and the first finger, these two, thenar space. Deep to the tendons, whatever tendons, FDS, FDP, FPL tendon, deep to them, near the metacarpals. And then there is the mid palmar space, which is, as the name telling, mid palm, related with these fingers. So any infection here can go to mid palmar, and any infection here can go to the thenar space. There's a septa here separating the two. These are two spaces. Now two more. There's a cerebral sheath on the flexor pollicis longus, creating radial bursa, can be infected, another space. And then there is FDP for the little finger, flexor distrum profundus for little finger, ulnar bursa. So total 4 spaces. Thenar space and the radial bursa towards the thumb, and mid palmar space and ulnar bursa towards the little finger. So towards the little finger, A will be the ulnar bursa. Towards the thumb, the C will be the radial bursa. Otherwise, you see, this is mid palmar space and that is thenar space. As I told you, there's a septa separating the two. Now, screwdriver was going here in the mid palm. So mid palmar space, that is your question. Mid palmar, choice B, mid palmar. Mid palmar related with not these fingers. These fingers are thenar space or radial bursa. These fingers are mid palmar or ulnar bursa. Now, I used to teach this topic, stopped doing it for FMG, but you never know. So 15-year questions are important. And those 15-year questions, not only your FMGE, but also INI-CET and NEET PG. There's a blurring of boundaries. 57-year-old patient dimpling on right breast. Dimpling. If it is dimpling, then Cooper's. If lactiferous ducts are involved, retraction of nipple. If subdermal lymphatics are there, pure the orange. So this is the Cooper ligament. These are Cooper ligaments, pectoral fascia to the skin, Cooper ligament. They can cause this puckering of skin, retraction of skin, Cooper ligament. If there's retraction of nipple, something wrong with the ducts. Infiltration, cancer infiltration basically. And if you're talking about subdermal lymphatics, then pure the orange peel appearance. Subdermal lymphatics here. This is ductal infiltration by cancer cells. And this is Cooper ligament, which we are showing here. So Cooper ligament is the answer. Why? Because they're asking about dimpling on the breast. Question came, I think, umbilical hernia, anti-abdominal wall. But you should know Meckel's diverticulum. You should know urachal fistula. You should know omphalocele. And you should know gastroschisis also. I'm just giving you some idea, means all of these are important. But the question was on umbilical hernia, I believe. Now another question. Tumor on the left lobe, left hepectomy is planned. Which segment should I remove? I have read about 4 or 5 surgery books in last 4 or 5 days because this question came. And somehow it is seen that whether you're doing transplant or you're doing hepectomy because some tumor or something abscess is there, always try to leave the caudate lobe with the patient. Don't touch the caudate lobe. Whether you remove the left lobe or right lobe, always keep the caudate lobe, the third lobe, segment 1, with the patient. Very rarely you will remove the caudate lobe, especially in liver transplants. When you're trying to give it to the recipient, and you want more volume of liver. So caudate lobe is always left in the donor, except for if the recipient need more of liver, then you may remove caudate and give. But if you remove caudate, it's very difficult, means you are putting the donor in trouble. So there is a falciform ligament, anatomical lever, telling that this is left lever, that is right lever. But surgeons don't follow that. Surgeons follow Cantley's line, correcting the floor of gallbladder and IVC, which is middle hepatic vein or Cantley's line. Surgeons follow this. And what they do is the right lever is given to the recipient, adult transplant, and left lever is left with the donor, and caudate is left with the donor. Now, counting is clockwise. Caudate lobe is number 1, very small, hidden behind 4, and it is the third lever. If it is a third lever, then who is the left lever? Left lever is 2, 3, 4, and that is what you will remove in this case. Don't remove the caudate. Then what is 5, 6, 7, 8? 5, 6, 7, 8 is right lever. So 5, 6, 7, 8 is right hemilever. 2, 3, 4 is left hemilever. And 1 is caudate lobe, which is behind 4, is the third lever, caudate lever. Remember, behind 4A, 4 is large, so 4A, 4B. It is behind 4A that you have caudate lobe. Caudate lobe is having direct drainage into the IVC, though there are middle hepatic vein, left and right hepatic vein. This is left hepatic vein, that is middle hepatic vein, and this is the right hepatic vein. But caudate lobe doesn't drain into any hepatic vein. Caudate lobe drains strictly into IVC. Some important things. So what are you going to remove here? 2, 3, and 4A, 4B. All that you remove. Don't remove caudate lobe. 2, 3, 4. Because you're talking about left hemi hepectomy. 2, 3, 4. Always try to keep the caudate lobe in the patient. If not possible, extended left hepectomy can be done. When you say extended left hepectomy, then you may remove caudate lobe. But here 2, 3, 4 is the answer. Another question came. There are esophageal varices. Which vein involved? Answer was left gastric vein. Left gastric vein drains into portal vein normally. But if there is a portal hypertension, it can take it back and leading to esophageal varices. So normally left gastric vein will drain into portal vein, but when there's a liver cirrhosis, this blood will come back. And as it is trying to jump through the esophagus, there can be esophageal varices. And the culprit vein is left gastric vein. That kind of question came. 25-year-old woman, primary infertility, pelvic ultrasound, unicornuate uterus. Which embryological structure involved? Ovary come from genital ridge. There are 3 things found by Mullerian duct. What are the 3 things found by Mullerian duct? The uterine tube, the uterus, and upper 1/3 of vagina. So what is found by Mullerian duct, which is other name of paramesonephric duct? If it goes wrong, unicornuate uterus. That is your answer. So Mullerian duct, what are the 3 derivatives? The 3 derivatives are uterine tube, uterus, and upper 1/3 of vagina. Then we'll form the lower 1/3 of vagina. Lower 1/3 of vagina, lower 2/3 of vagina come from urogenital sinus, but it is endodermal. So endodermal urogenital sinus from lower 2/3 of vagina. It is the upper 1/3 of vagina, which is mesodermal, derivative of Mullerian duct. And since the Mullerian duct is also called paramesonephric duct, forming uterus, if something goes wrong there, you can have bicornuate uterus, unicornuate uterus. So this is urogenital sinus. You'll find there are mesonephric duct in the beginning. Mesonephric duct is the other name of Wolffian duct. Now on the side of that will come paramesonephric duct, which is the Mullerian duct. And they unite in the midline, and then they open into posterior wall of urogenital sinus. It is they will form uterine tube and uterus, and also upper 1/3 of vagina. So it is para-mesonephrine duct because it is on the side of mesonephrine duct, para-mesonephrine. I have a diagram also. If it is uterine tube, uterus, or upper 1/3 of vagina, then it is from Mullerian duct. If it is lower 2/3 of vagina, endoderm of urogenital sinus. Vaginal epithelium, lower 2/3 is endoderm, though later it will encroach entire vagina. This is the mesonephric duct, which is Wolffian duct, forms male systems. In female, it is Gartner's duct, remnant. But this is para-mesonephric duct because it is coming on the side. It unites, forming uterine tube, uterus, and upper 1/3 of vagina. So para-mesonephric Mullerian duct form uterine tube, uterus, and upper 1/3 of vagina. There can be Mayer occupancy, Custer-Hauser syndrome, Mullerian anomalies, uterus missing, uterine tube missing, upper 1/3 of vagina missing. They are all Mullerian anomalies. In male, because we have Mullerian inhibiting substance, you will not have uterus in male. It is called prostate utricle, a remnant of Mullerian duct in male. So lower 2/3 of vagina is endodermal of urogenital sinus. Here you will keep your answer as para-mesonephric because you are talking about unicornuate uterus. Which ligament tested? You are pulling the tibia anteriorly. ACL, you are checking. Anterior droid test you are doing. 90°. So if you're telling this is ACL, which normally prevent anterior displacement of tibia, if it is torn, you may have anterior droid test positive. So normally ACL prevents anterior displacement of tibia, but if it is torn, then you can pull the tibia anterior. Anterior droid test will come positive, ACL injury, but it is painful because you are doing it at 90°. You can modify it as Latchman, which is done at 30° knee flexion. Hamstring will not be giving resistance in this position, so less painful. And 93% specificity, 87% sensitivity, highly specific, highly sensitive, Latchman. Both of them, you have to pull the tibia anterior. But in Latchman, you have to fix the femur with one hand. So with one hand, you fix the femur. With other hand, you are pulling the tibia. See, one hand fixing the femur, other hand pulling the tibia. This is Latchman. But they are for ACL only. ACL is a ligament attaching anteriorly on tibia, running backward, upward, lateral, attaching to lateral condyle of femur. ACL can be damaged in triple triad with medial meniscus and tibial collateral ligament. So tibial collateral ligament and the medial meniscus and ACL injured in triple triad syndrome. Football players, American football players. Then the anterior droid test will become positive. So ACL anterior droid test. This is not Latchman because Latchman is 30° maximum. Now asking about this type of questions: sustained trauma, lateral side of right knee, police lathi charge, Delhi police hitting below the knee. You must have seen what they hit. They hit below the knee, neck of fibula, conperineal nerve, patient left foot drop, and patient will lie on the ground. That is what police lathi charge is about. Remember that. So difficulty walking, toes keep dragging. They'll have a high steppage gait. All of these are MCQs. So of course, neck of fibula, because conperineal nerve winds around the neck of fibula. Now, if conperineal nerve is damaged, winding around the neck of fibula, the superficial and deep perineal will be compromised. If superficial perineal nerve is compromised, peroneus longus brevis is compromised. Foot eversion at subtalar is compromised. Foot eversion is gone. Plus sensory loss on the lateral leg and also most of the dorsum of the foot, except for the first interdigital space because that is deep perineal nerve. What about the lesion of deep perineal nerve, which is also called anteriotibial nerve? Four muscles it supply: extensor tom, dick, and Harry. Extensor tom, dick, and Harry means tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. They will be compromised. So extension or dorsiflexion at the ankle is gone. There'll be a foot drop. Patient will not only have a foot drop, there is a loss of foot eversion because social perineal nerve is not working. Of course, foot dorsiflexion, toe dorsiflexion is gone because they are done by deep perineal nerve. Deep perineal nerve supply dorsum of the first interdigital space, L5 dermatome, foot drop, and there will be a high steppage gait. High steppage gait. All of these are MCQs. Remember the dermatome, little toe, lateral foot S1. The great toe is always L5. The medial malleus, medial leg L4, that is saphenous nerve. Saphenous nerve is L4 to medial malleus, medial dorsum of foot, branch of femoral nerve. Sural nerve is S1. It is not a branch of femoral, it is branch of tibial nerve. The first interdigital space L5, deep peroneal nerve. Let me zoom. Otherwise, most of the dorsum of the foot is under superficial peroneal nerve. So this is all territory of superficial peroneal nerve. And if you go to the great toe, it is L5. So it is the dermatome. Sometimes questions come on dermatome. Here we'll keep our answer C because C is the neck of fibula. This is a territory of common peroneal nerve. Maybe fractured neck of fibula. Police lathi charge, Delhi police. They do that. They are trained to do that. It has some scientific logic. Which bone? So you're looking from the superior view on the right foot. Superior view right foot. You know, there is a talus bone, head of talus articulating with navicular, boat-shaped bone. Boat-shaped bone navicular, boat-shaped bone navicular. It is on the medial side. Medial side is great toe. Great toe is medial side. Embryologically, great toe is medial side. So you were asked about navicular. Lateral bone is cuboid. Lateral bone is cuboid. There will be a CC joint also. CC joint, saddle cervical joint, lateral longitudinal arch. So lateral longitudinal arch, CC joint, calcaneo cuboid joint. But medially you will have talocalcaneo-navicular joint. Talocalcaneo-navicular joint, medial longitudinal arch towards the great toe, ball and socket. It is ball and socket. So when you say talus, calcaneum and navicular joint, that will be ball and socket forming medial longitudinal arch. But if you say CC joint, calcaneo-cuboid joint, then it is saddle cervical joint forming lateral longitudinal arch. So identifying them on X-ray is good. The lateral cuneiform, middle cuneiform, and medial cuneiform. Cuneiform bones. The lateral cuneiform, middle, and medial cuneiform. So just try to identify them. This is the heel bone, largest of all, the calcaneum. There's an overlapping of talus bone here. So talus, calcaneum, cuboid, navicular, medial cuneiform, middle cuneiform, and this is medial cuneiform, middle, and this is lateral cuneiform. Lateral towards the little toe. Little toe is lateral. All the things given here also. So they were marking the navicular, boat-shaped bone towards the great toe. You know, what is this? This is venous structure, dilated, elongated, tortuous, varicose. Dilated, elongated, tortuous, varicose vein, great saphenous vein. Why? Dorsal venous arch continuing as great saphenous vein towards the femoral vein. It's a superficial vein. Normally, superficial veins drain into deep veins, and there is a perforator here. Like you have Cockett's perforator, supra-ankle Cockett's perforator. Below the knee, Boyd perforator. Above the knee, you have Dodds perforator. Mid-thigh, you have Hunter's perforator. These perforators, they prevent backflow. But if perforators are gone in long-standing cases, like bus conductor or a neurosurgeon standing for long hours and not using the soleal movement, the third peripheral heart, then these perforators go and this vein will be filled with a lot of blood. Ulcer can also come. That also came as a question. So it is dorsal venous arch, medial marginal vein, dorsal venous arch continuing as great saphenous vein running on the middle leg, middle thigh, though it goes behind the knee also, and drains into deeper vein, which is femoral vein. And related to that is saphenous nerve. When you do venous cut down at the medial malleus, they are anterior to medial malleus. So when you're working on saphenous, long saphenous or great saphenous vein for CAVG operation or venous cut down in burns patient or varicose patients, you have to be careful about saphenous nerve because saphenous nerve, if it is compromised, dorsum of the medial dorsum of the foot will be compromised. L4 dermatome. So the ulcer which you get here is venous ulcer. Location of venous ulcer is mostly here. If the arterial ulcer like Berger disease or peripheral vascular disease, Berger disease or thromboangiitis obliterans, arterial ulcers, diabetic ulcers, neuropathic sole, pressure soles if the patient is lying supine for a long time. So pressure soles, diabetic foot, neuropathic, arterial, and the location. Plus they have, edges are healing kind of. They heal. If you remove the varicosity, they'll heal. Shallow they are, shallow margins. The arterial will be deeper and edges will be not sloping. They'll be like you have dug some hole like that. So here it is, great saphenous vein. That is what you will keep your answer. I was told to stop at 7:30. I have taken 10 more minutes. Thank you very much for your patience. All the best. And study well, study hard, study smart, become a better, efficient doctor. That's all we wish for. That's all we try for. V for victory. Take care. Bye-bye.